Hello and welcome to another audio podcast. My name is Jack West and I'm a medical oncologist at Swedish Cancer Institute in Seattle, Washington. I also serve as the president and CEO of GRACE, the global resource for advancing cancer education. And I'm happy to be here today with Dr. Sarita Dubey, who is a medical oncologist who actually works in both the medical oncology and radiation oncology departments at UCSF Cancer Center in San Francisco. So thanks for participating. Thanks for coming.
Hello, Jack. It's great to be here.
A transcript as well as a PDF file with copies of figures associated with this program are available at www.cancergrace.org/GRACEcasts. What is your current favored postoperative approach for patients who undergo surgery for, let's say, a stage 2 non-small cell lung cancer?
So I always recommend a combination regimen, platinum with an additional drug. If we get into specifics, I prefer cisplatin over carboplatin if a patient can tolerate it. Now, I know that studies have told us that cisplatin with vinorelbine is really the best, but we don't know for sure whether anything else is inferior to that or not. So, given that vinorelbine is really hard to get through the treatments, it's a weekly treatment, the cell counts really drop with every weekly treatment. It's been an incredibly difficult treatment for a lot of my patients. So now I have been following what the guidelines are for the new adjuvant clinical trials, the clinical trials that are looking at chemotherapy after surgery. Now, these trials are allowing or permitting other chemotherapy drugs in combination with cisplatin. For example, they are allowing Taxotere, they are allowing Alimta, otherwise known as pemetrexed. So I have been following those guidelines.
Obviously, we need to individualize some for the patients in the postoperative setting, and a lot of our patients are also older, potentially frail. What kind of approach do you use for, say, a 70, 75-year-old who is perhaps on the border of being able to tolerate chemotherapy? Do you recommend it? Do you prefer carboplatin over cisplatin, or what do you think about for them?
So there's no direct answer for that. It's a combination of a lot of things. So one, I always reference clinical trials, trying to be evidence-based. So there was a Canadian study which had treated people with chemotherapy after surgery. And even though it wasn't planned at the time they started the trial, much later they looked back at how their patients did and found that when the patients were over the age of 75, that additional chemotherapy after surgery really didn't help. So I keep that in mind and I discuss this with my patients. And not just the age of 75, I look at the overall condition of my patient. Are they otherwise healthy? Are they otherwise active? Do they have a family history of living to 95 or 100? And how aggressive do they want to be? So I keep all of these in mind, have a conversation with my patient, and then we decide whether we do want to do additional chemotherapy or not. I did have a patient who was 78 years of age. This was a year ago. And we went over the same issues, and we together made a decision of not taking additional chemotherapy. And the fact is that additional chemotherapy does improve your cure rates, but it's not 100%. So after a very detailed discussion, this man took the decision that the chemotherapy may not help him. It may in fact end up hurting him. So he decided not to take the adjuvant therapy, and he's never regretted it after that decision.
Well, that gets to another question. That is, when you are discussing adjuvant chemotherapy, how do you frame the anticipated risk-benefit of it? What kind of benefit do you tell people they might expect from postoperative chemo?
So if we're talking about people below the age of 75, I think that's the easier conversation, because I think, given what we know, the benefits outweigh the risks, because the risks of chemotherapy, for the most part, are early side effects. They're manageable. The nausea is manageable. The drop in the cell counts is manageable. The things we talk about that can be long-term are the nerve damage, the neuropathy, so the sensation of numbness or tingling in the fingers and toes. That can be caused by some chemotherapy, not all of them. And when that sort of neuropathy develops, it can last a very long time. With most of my patients, in fact, invariably all my patients, it lasts for months, but it's usually gone by the end of a year. And so I have a very frank discussion with my patients. But the truth is, a sensation of numbness or tingling for 6 or 8 months versus chance of cure for cancer. I think the decision there is quite easy, not just for me as a physician, but for my patients as well. Now, could there be really long-lasting side effects of chemotherapy that we don't know about? There are the possibilities, because we've only been practicing chemotherapy after surgery for the past 5 years. So there are possible long-term side effects that we don't know about. But we tend to go with what we know, and what we know is chemotherapy is helpful.
Do you routinely recommend postoperative chemotherapy for patients with stage 1B disease?
Not routinely, but only specific cases where the tumor is particularly large. And again, I have to shamelessly refer to clinical trials. And there was this one trial that showed us that in 1B, there are different types of tumors that qualify for 1B. And the particular set of tumors that were all greater than 4 centimeters, that chemotherapy helped. But in other types of 1B, chemotherapy didn't help. So, say 3 centimeters with other characteristics, chemotherapy did not seem to help. So I have been following that clinical trial data to recommend chemotherapy or not. We also try to enroll patients onto clinical trials if possible. So that's another opportunity for patients with 1B whose tumors are less than 4 centimeters that I normally wouldn't have given chemotherapy. And again, since this specific area is not as clear-cut as many others, it is a discussion that I hold with patients. I have had a discussion with one patient who, even though the tumor was 5 centimeters, had declined chemotherapy after surgery. And the truth is, even though we have information about adjuvant chemotherapy, it's important to realize that the patient really has a role in making this decision.
Are there any patients with a stage 1A cancer that you would recommend chemotherapy for based on the grade or the patient's significant desire to be aggressive, or would you really consider that the risk may outweigh the benefit for all stage 1A patients?
Until today, I haven't treated a stage 1A with adjuvant chemo.
At ASCO last year, we saw some data that you mentioned earlier about the ILT trial and the late follow-up of these patients, showing that there were a higher rate of deaths in the chemotherapy-treated patients compared to the patients who had undergone observation beyond 5 years. Does that change your approach to adjuvant therapy or your enthusiasm for recommending it to patients?
It hasn't, because when we look at the other adjuvant trials, the Anita trial in particular had long-term follow-up for 7 years. And it maintained at 7 years that adjuvant chemotherapy does improve survival. And the survival increment at 7 years was similar to the survival increment at 4 or 5 years. So there is one study whose results are in contrast to the EALT study. Another example is the Canadian JBR10, where the survival improvement was 15%. So if we look at JBR10 with a survival improvement of 15%, we look at the Anita study, which showed a survival improvement maintained at 7 years. The EALT is the only outlier where the survival improvement was only 4.5% at 5 years and not maintained at 7 years.
Do you change your approach at all for a patient who is a never smoker, or if you happen to know that they had an EGFR mutation, would that change anything for you?
It would want to make me change, but the truth is, I think I'm a creature of habit and practice evidence-based medicine, and unless there's evidence that proves that, well, you're alluding to the use of erlotinib, which is well known to help people with metastatic or stage 4 lung cancer when they get erlotinib. And so would we feel pressed to use that drug earlier if they had a surgery? So I don't use it, though I must say we do have a trial where patients have the opportunity of getting erlotinib after their surgery and chemotherapy. It is a randomized trial, so the choice is not by the patient. A computer decides whether the patient will get erlotinib, which is known as Tarceva, or whether they get a placebo pill. So I do discuss this with my patient, and there are some patients who would like to participate in the trial, and there are some who don't because they don't like the idea of getting a placebo. In the absence of proof that drugs like Tarceva can help the cure, I cannot routinely recommend it to my patient.
Are there patients in whom you would recommend preoperative chemotherapy under any circumstance?
So we do tend to recommend pre-op chemotherapy, and pre-op chemotherapy tends to be more an institutional-based practice. And the reasons we do it are several-fold. First of all, we know that surgery alone does help cure people, but when we add chemotherapy to the surgery, it helps the cure rate go up a lot more. Now, once people get lung cancer surgery, it's difficult for them to take chemotherapy afterward. It's much easier to give chemotherapy before the surgery than after the surgery. So right there is one advantage of giving preoperative or otherwise neoadjuvant chemotherapy. The second reason is that we know that when certain cancers, they metastasize or spread to the mediastinal lymph nodes, which are the lymph nodes in the center of the chest. We know that when these people are treated with either chemotherapy or a combination of chemotherapy and radiation, and if we can clear all those cancer cells from those lymph nodes and then we perform surgery, that their cure rate is much, much higher. So we as an institution have believed in the neoadjuvant or the preoperative chemotherapy approach, and we still continue to use it for some patients.
Do you use that for patients who you might want to convert from a potential pneumonectomy to a lobectomy?
That's a very good question, because you would assume that if you could give chemotherapy and shrink the tumor, you could convert a pneumonectomy to a lobectomy. But the truth is, it never happens that way. So we do give the neoadjuvant chemotherapy, but it doesn't change our surgery. So why do we do it? Because we know our patients need neoadjuvant chemotherapy. Because if people have mediastinal lymph nodes, those lymph nodes, if they are cleared with chemotherapy, their chances of cure rate are better. Secondly, from studies, we also know that if people are not able to clear their lymph nodes from chemotherapy or chemoradiation, then perhaps those are the people who don't benefit from additional surgery, that perhaps surgery doesn't add anything to them. So in fact, a neoadjuvant chemotherapy approach helps us decide what the future treatment needs to be.
At your institution, do you do a mediastinoscopy after induction therapy to see if they've cleared their mediastinal nodes?
Yes, it is done, and the mediastinoscopy is done on the same day that the patient is actually planned for surgery, so that the surgeon does the mediastinoscopy, and if we find that there's only one level of mediastinal lymph node involved, or if none are involved, then they can proceed to surgery. If it's much more than that, then the surgeon does not proceed for surgery, and the patient readily then gets moved into the mode of getting radiation.
For your 3A patients who are planned to potentially go to surgery, do you routinely do chemotherapy alone or chemotherapy and radiation, or does it depend on the individual patient and their tumor burden?
It really depends on the tumor burden.
Do you have any particular regimen that you favor using?
So we have been using the SWOG regimen. We know that SWOG has done many years of research on patients with stage 3 disease, and they have had a good track record with the true drug cisplatin and etoposide. So we tend to use that a lot with radiation. Now, if we are treating a patient who is older or whose kidney function is not good, whose energy level is not good, we know that cisplatin etoposide is going to be really hard on their body. Now, there is another regimen of carboplatin and paclitaxel, as opposed to SWOG that use cisplatin etoposide. CLGB, the other cooperative group, did a lot of studies with carboplatin and paclitaxel. So we have indeed used carboplatin-based regimens for some of our patients.
Well, thank you very much for taking the time, Sarita.
It's a pleasure being here. Thank you, Jack.